No, that is, we said shouldn't show anymore. There are other names out there.
I'm a librarian, I should have been able to find it.
What's that? Binary literacy. Might not find it in that world.
I don't know. That was an expensive degree, so.
It's real.
If I can't, then I'll be pretty,
That's that post.
yeah. Okay. So, I'm just introducing all of you guys up first. And each one of you will just go through and talk about what you're involved in, what your questions are, whatever you want to plug. Okay? So, I will jump to go from, well, your last. No. My, yes, good one, correct, yes, starting with, Master Watson.
So you, yeah. Let me make sure my phone is. Oh.
It's always bad when it's
I know
your
mine
own
was.
phone.
Yeah, I know my phone was.
How rude. Whose phone is that? And then it's your own. And everything. I feel like I said the same. Everyone else will say it.
All right. You do.
They don't have
That's all I have. So, direct everyone.
Yeah. From the VX, he was gonna come?
both of these.
Yeah.
They could come anyway, although. My kids. My kids, my workers. Actually, almost.
No.
Yeah. So it's coming down to the line it down.
You shooting?
Yeah.
What do you got?
No, but just going up, we can bring it into it.
Yeah, they came in somebody actually, they're mostly shooting the ID campaign that I'm doing. So they're doing. So, I want to relaunch, and that's what we're going to talk about. I want to relaunch the September.
Yeah, please.
Yes.
Yeah, super excited. It was. I got this project.
Yes.
It would be a great place to.
Coming up,
All right, everyone. Thank you guys so much for coming out tonight for Health Literacy in the Margins, Brooklyn Bridge first discussion panel. Thank you so much. First off, I want to give a round of applause to all you guys. Thank you so much. I know it's a tense way to start, but you know, that's what we're all about here. So my name is Darren Flynn, and I'm a literacy advocate and a member of the Brooklyn Bridge Chief Matter Star program at CMU Downstate. Before we begin, we just have a quick announcement.
That's for me. I'm Adam, and that's Hendrik over there, and we're working on a documentary. We've been following Kim for a while now, and we just wanted to announce that. And also, if you don't want your face to be shown, to let us know, and we'll make sure not to put it on the documentary. So just let me know if you see me pointing a camera at you, just wave me down, and I'll go.
All right, thank you. All right, so before I start off introducing the panel, I'm just going to introduce our esteemed panelists here. First things first, we have Dr. Kim Watson, the founder of Community Kinship. We have Sasha Alexander, founder of Black Trans Media. We have Nathan Levitt, RN, who is an oncology nurse at Maimonides and also a consultant for Cal Ward. And we also have Dr. Dahan from Star Program Clinic. So I just want you guys to each give a few words about yourself and your experience, starting with Dr. Kim Watson, please.
Hi. We can just give this evening. I'm one of the co-founders of Community Kinship Life, and our mission statement is to actually provide services medical services for the transgender community, that's trans masculine and the trans feminine community. And we also have holistic therapy. I have a background in health. My graduate from Pace University. I do a lot of HIV and AIDS awareness, as well as do the surgery scholarship fund for CK Life. And what we do is make sure that we award individuals with fundings, which was like 51,000 this year so far, ready to provide surgeries for individuals. Gynecology, that we find an insurance specialist because a lot of insurance doesn't pay for that. But as we go along, you will get to know me, and if you want to, you can ask me questions. Thank you.
I'm Sasha Alexander. I'm the founder of Black Trans Media. I'm also a filmmaker, educator, community organizer, and Black Trans Media exists to reframe the value worth of Black trans people, and particularly look at the intersection of the experiences of Black trans men, women, gender non-conforming folks. And so some of the things that we're working on is actually creating and supporting media that's out there by Black trans people, artists all over the country, all over the world, producing our own work with Black trans people here in New York, and hosting community events to kind of build community, bring folks together, and even highlight what those experiences are that people want to be producing more work around and see in the media that they're not seeing. And I'm excited to be here. Thank you.
Hi everyone, I'm Nathan Levitt. I have been working as a nurse for about 3 or 4 years, and I've been working as a trainer for about 15 years. I do a lot of trainings on specifically transgender healthcare for medical schools, nursing schools, hospitals, health centers, and I myself am transgender, so I talk about my own experience as well as talk specifically about medical issues for transgender people navigating healthcare. So that's a lot about what I do.
Hello, my name is Dr. Elliot Dehan. I'm an infectious disease physician by training, and I am currently working at the Star Clinic at SUNY Downstate Medical Center, where I provide HIV as well as hepatitis C services. Also, we are in the process of expanding these services to include PrEP for HIV negative individuals. I have particular clinical interest in LGBT health. Prior to my work at STAR, I was the HIV medical director at Community Healthcare Network, and also served as a clinician in their transgender primary care program, providing hormone therapy for trans women and trans men at CHN.
All right, thank you very much for introducing yourselves. We're going to go ahead and get started. The first thing I want to discuss is the importance of health literacy. That also begins with defining what health literacy is. Now, health literacy is defined as the capacity to understand and navigate healthcare systems and healthcare information, medical resources, and any kind of information that has to do with your mental well-being, your physical well-being, and holistic well-being. And everyone needs to be health literate in order to maintain strong bodies, sharp minds, and full lives. Sadly, there are many obstacles to healthcare and to being a health literate person, and those obstacles are not equal for everybody. For marginalized communities, there's often an intersection between, there's often a correlation between the ability for someone to access and navigate information related to healthcare, related to financing healthcare, and related to sharing in the experience of a full and healthy life. That are related to their experiences as either a person of color, as a person of trans experience, or what have you. So Brooklyn Bridge is particularly interested in how health literacy is important for the communities that we focus on. We focus on, of course, people of trans experience in the Brooklyn area, people who are facing economic barriers in the Brooklyn area, as well as the people of color, particularly the African American community and the Caribbean American community within Brooklyn. And so there's some unique challenges that we're interested in peeling back the layers of and looking at why it's important to be particularly health literate or a certain type of health literate when you're a member of these communities. So thank you very much for coming here to help explore these issues. I'm going to direct my first question here to Dr. Watson, to Kim, and to Sasha here. If you could answer this question first. So, can you describe your experiences and the experiences of the people that your peers and people that you serve through your program, the community kinship, navigating medical and mental health care, particularly as people of trans experience? And what are some of the things that were available to you, and how have things gotten better? And what are the challenges that still are there?
Well, the challenges that I've had is that, well, I don't identify as transgendered. I'm anatomical female, which means post-operative. And my services to transgender individuals is that I deliver so much services like the support and educating that. But for me, the reason why I do this work since 2007 is because me as myself, during medical transition, I never had these resources. So to come up in a place in New York City without any kind of resources, those were my challenges. There were nothing, I'm right here in my stomping ground in Brooklyn, and there was nothing considered as a Brooklyn community center or LGBTQ individuals. So I decided to shift that, and as I move forward in my life, I never forget where I came from. So I decided to provide those kind of services for individuals that are of transgender trans experience, male and female. And then I decided to have a co-ed support educational group so that these individuals could, if they can get the services at different agencies, be able to get those kind of services, a much more intimate process with communication line.
Thank you. Sasha, same question?
I mean, I guess just you were talking about some of the things in particular, like the barriers we have to deal with. And I guess one of them is just how binary the medical system is. And even like as a trans person navigating the medical system, how binary it is. And whether that's like within our own community or coming from providers outside, there's a certain message around if you are masculine or feminine, like what health even should look like, what you should even be receiving. And there's a lot of assumptions around what that process should be or who you should be in that process. And I think that's something that I was challenged by a lot, not only because the services were not necessarily culturally competent, like I didn't necessarily want the same things as other people for different reasons, but then there was a need to have to fit into either, if I was a trans masculine person, then I needed to go down a certain road, and I was expected to do certain things, even by medical providers. And still to this day, I mean, I'm a gender non-conforming person. I am masculine, but I use he, she, they pronouns. Like there are all sorts of ways still that I live my life as a gender non-conforming person, like both the way my ID works, the way my name works, and those are decisions that I've made because I embrace being a gender non-conforming trans person, but the healthcare system doesn't know how to embrace that, doesn't know what that looks like or how to even be sensitive or aware, because people are at a place where they think, well, if you're a trans man and I talk to you this way and you use these pronouns and you want these services and you have this sexuality, and those things have actually been really counterproductive to what we've actually needed, because a lot of us are then like very secret about what we need as trans people already because of a lack of accessibility to resources. And then if we don't fit into this particular trans box, we find ourselves even more kind of isolated in what we need health-wise. And so that's something just for myself that I dealt with a lot when I was first coming out and trying to figure out, I'm still trying to figure out, I think, always how to access health resources that actually feel good and come from a place of love or community, and rather than like these institutions or systems that kind of don't personalize what we need. So that's been one big barrier.
And a quick follow-up to what you discussed, what you've laid out there for us so articulately. When the healthcare system as is refuses to acknowledge and personalize, or has a struggle, not refuses to, but has a struggle with acknowledging personalized healthcare and creating these kinds of legitimized avenues for a person to build their own path within the healthcare system. Have you seen in your community people creating avenues that are not necessarily legitimized? And I'm using legitimized, not legitimate, because, of course.
Yeah, kind of alternatives. I mean, I think there are people who are doing those things. There's less knowledge about them. Like a lot of people get information from a YouTube channel where somebody's sharing their experience, but then only certain people are even going to put that experience out on YouTube or are going to share that. And I definitely think in terms of the holistic stuff that Kim speaks to, there's not a lot of people looking at that intersection of what we need outside of, I don't know, just certain ideas of medical needs. But I don't even know if I'm answering this question the right way.
You're doing a great job.
I don't even know what I'm trying to say. I guess the thing that I've found is actually speaking to other gender nonconforming people. That's the only tool or resource that I feel I have out there is to actually speak to other folks who are navigating the systems, have had to navigate those systems, and each as individuals we come up with whatever way we feel comfortable to be able to do that, or affirmed in being able to do that. But so much of that is being able to not feel isolated, and that I'm the only trans person that has an experience, even within being trans and seeing a provider about being trans. So I think a lot of it is being able to have community around that experience, and even I guess I think there's more visibility around gender nonconforming trans people I guess popping up, and that's helpful.
And Kim, what do you have? Do you want to add anything along those lines of people that you've worked with that have found avenues around an institution that they might feel struggles to recognize themselves?
Well, before I was working, I started the first transgender program within Community Healthcare Network, and I was there for 8 years actually in the Bronx. That was the first transgender medical program I ever started, and there was the barriers were what we struggled with for up to 8 years is that the use of pronouns, and individuals were coming in, and my whole thing was to get individuals come in and be managed with hormone replacement therapy instead of have to use them on the street or go to black market hormones or anything of that nature, because they were afraid of how the medical facility or the whole medical resources would actually treat them, or whether their pronouns or whatever. So that actually would turn them away. But to have someone in there that navigated that system, to let them know that there's someone there that would understand what you're going through and relate with you, hopefully, at that point in time. So those are the things that I'd be able to reach out to the community to say, come on in, we are here as a medical staff, but actually we're here to actually help you. And I help them be much more trusted individuals and confident individuals. Matter of fact, confide in the medical system, because there are not too much medical facilities that you can go and really get adequate quality service.
Thank you very much. All right, Nathan, I want to give you the opportunity to kind of respond to some of the things that were raised, both in the answers that Dr. Watson, that Kim and Sasha have raised, and if you want to unpack anything in those particular answers.
Sure. I mean, I think that I have a interesting position because I'm both a trans person that navigates healthcare and a trans provider of healthcare. So it's always really interesting to walk both lines. And I really appreciate the stories that you all shared, because it really brings up how difficult it is for trans people to navigate healthcare, either because they don't know the resources that are out there, or the resources that are out there are not trans-sensitive or trans-affirmative. So from my own experience, it's been, I feel like I haven't had as many resources coming out as trans, and also having to tell a certain script, there's certain language that we learned to tell mental health care providers and medical health care providers in order to get the things that we needed. And it's interesting for me on this end to talk to trans people and say, you don't need to give the script, right? You don't need to say you knew your whole life and you want hormones and you know this is exactly what you want and you're very, and although for some people that is their story, right? But for other people it may not be that they want to go, they want to be on testosterone, they want to be on estrogen, they want to have surgery. Not everybody wants that, right? And not everybody knew since they were very young. So it's interesting to try to convince other trans people that it's okay to be honest about your life and about your experiences. And it's something that I do for the trans patients that I work with, but that it's hard for me to do with other healthcare providers. So it's interesting when you learn how to advocate for your patients, but then you have a hard time advocating for yourself in the healthcare world. I'm sure a lot of us have similar experience around that. So being able to train healthcare providers, which is a lot of what I do, I try to give them the experience of a transgender person navigating healthcare so that they know all the different barriers that are faced and why there's so little trust with the medical community, because there's so many hoops that we've had to jump through, right? So a lot of my work is helping to kind of break down those barriers, but also be very understanding of where those barriers come from.
And Dr. Dahan, I would like to hear how you would like to unpack that.
Absolutely. I mean, one thing I really, push and tell other providers that I'm training is that there's a real need for training and sensitivity among medical providers about issues related to the trans experience and proper use of pronouns as well. And I think that's something very almost simple to do. Like, we can teach medical providers how to use pronouns appropriately and find out how our patients would prefer to be referred to, whether they prefer to be referred to as he or she or they or whatever the pronoun of choice that they have. So I think there's a real need for training of medical providers. I also think it brings up another issue. We're talking about health literacy. There are a whole lot of things, as you were mentioning earlier, that persons of trans experience need to be informed about in order to be health literate, and one of them is, the consequences and side effects of hormone therapy, for example, and that's something that a medical provider has to kind of walk them through. And I don't think there's enough training in medical schools and also medical training programs, residencies, and fellowships along those lines. And a lot of providers are scared and don't know. They are all scared of the side effects, and fear is not a good modality to work out of. And so I think we really, this is a great group, Brooklyn Bridge. We need to kind of bridge the gap between particularly persons of trans experience and providers, and really kind of get over the fear of the providers, and also help persons of trans experience not feel afraid of the medical system that is hard to navigate as well. So I think there's room to work there.
Next. Thank you very much. I'm going to switch gears a little bit here and start talking, or maybe just move with the natural progression of what we've been talking about. We started talking about the actual health literacy of the patient of trans experience, and now we're kind of going across that gap, as you so articulately laid out there, to the healthcare provider. And I want to start off by asking this question, and I'll start with you, Dr. Dahan. Is it safe to characterize medical practice, particularly traditional medical practice that a lot of people have had to experience up until this point in this country, as assuming a gender conformity? And what kind of roadblocks that still exist, the lingering roadblocks, kind of show that?
There are a lot of roadblocks. I even think, one very practical thing that I have been talking about earlier are electronic medical records. We're pushing in this country to use electronic medical records, which have a lot of advantages, but one of the issues that we have encountered at a place I've worked at when we serve patients of trans experience is the gender entry into the EMR. Which gender do you put? And it may seem like a simple question, but the insurance has one answer, the patient has another answer, and the clinic has another answer. And nobody's answer really is in line with each other's. And so That's one barrier. I think we really need to work with managed care companies to work together with the providers and the patients to kind of reach a solution there. So I think that's one barrier. Definitely. I think we need to move away from a paradigm where we have male or female as the only option, and have other options that also are accommodating to gender non-conforming as well. And maybe perhaps have different fields within electronic medical records that kind of accommodate and can account for all these different perspectives on gender. So I think that's one thing that we definitely can do. I would definitely start with that. I also think that in terms of the gender issue is important because insurances will only cover hormones based on your gender classification according to the insurance. So that can raise a whole slew of issues and often requires letters to be written to the insurance company in order to change that so the patient can get their proper medical treatment. I think I'll leave it at that. My colleagues also.
Yes, Nathan. I know there's a lot that we can cover here, but
No, definitely the electronic medical records are huge, and at Callan-Lord and at hopefully other places, when patients walk in, or as a trans patient when I walk in, the first thing we do is often look at the registration form, right, and figuring out, like, is this going to be a comfortable place? And the hospitals and the health centers that I train, they don't have as much room to maybe change the registration form. The very large hospitals have a really difficult time with this, although places like NYU Hospital and other hospitals are starting to make that change to allow for transgender options. But the questions that patients will most likely have are, what do I check off, right? Do I check off the gender I was born as, the gender I identify as, to think about what is going to get covered and what isn't? So as a transgender male, if I'm going to the gynecologist, I'm going to check off male because of the way that I look, but what's going to get covered is I'm thinking about what's on my health insurance card, what's on my license, how I look, what the experience is going to be like from the waiting room to the nurses to the doctor, all the way through, right? So everything about that is really difficult, and you're thinking about all these different avenues and how gendered these places are. So thinking about bathrooms, thinking about registration forms, thinking about what script you're gonna say to your healthcare provider to get the things that you need, right? So all of those things are very gendered, and we try to, in the trainings I do, try to break down those barriers. But there's things that we're caught in, right? Because insurance and billing and all of those things are going to go by what's legal and what's getting covered. And so sometimes it's a lot of working with the patient to talk about what are the things that you want to get covered, what experience do you want, right? So do you want the experience where you walk into a healthcare center and your identification is going to match the way that you look? Or do you want the experience where it may not match, but you might get things covered that are gendered, right?
Yeah.
So those are the huge questions, and and not everyone has that choice to decide what's going to be on their on their identification form, because things are legally changed through surgery, through therapy, through all these different avenues. So those are just conversations. There's not a lot of answers, but I think those are conversations that healthcare providers or case managers or mental health workers should be having with their patients about what their experiences are going to be like in a very gendered society, and how to work around it, right? When you don't have an option of checking off something different. So the Callan-Lord registration form, and I think a few others, will at least explain why you need information like your legal name and your legal gender. Because as transgender people, when we get asked that, we think, why do you need that? And what is this about? And what is it going to be connected to? And it will say, we're asking this information for billing purposes and insurance purposes, but we're also going to ask you your chosen name, your chosen gender. So those are places, not everyone has those options. So it's very difficult as a trans person, but then also as a healthcare provider, to work in a very gendered system.
Absolutely. Sasha, I want to give you first the opportunity to respond to the actual institutional problems that we have discussed thus far. But one thing I just thought of was that we see a lot, oftentimes, particularly in New York City, in the greater New York area, that there are health disparities that are kind of predisposed by race. So as is a person of color in the city, has these particular statistics in terms of health disparities. And then on top of that, particularly people of color who are also of trans experience have to navigate another level of distance with the healthcare system, another level of disconnect with the healthcare system. So in kind of responding to these institutional questions that were raised, can you, I want to see if you can speak to some of those issues that are also brought about by like circumstances of race, if you can, if you'd be so kind.
No, I mean, I guess earlier when we were talking about what are some of the barriers, I was thinking, I mean, when we were bringing around the history of people's experiences with the medical field, or like just as a Black person, like I think about the Tuskegee experiments, or like other experiences that like Black people have had, let alone like the intersection of me as a Black trans person, and then the experiences trans people have and being tested on or whatever, shock therapies, all sorts of different things. And I think, you know, it is that intersection that on top of all the like things we have to deal with makes me feel like, well, I'm not even going to go to the doctor, because that's a space where I either can't get there because I can't leave work and I don't have insurance, or I don't have the money to like get there, or once I get there, I'm going to have to deal with somebody, whatever, some form of something, you know. And then I think about the binary part, the hard part is like, I've been to places where I fill out a form that says like as accurately as I can who I am, and like, you know, I meet a provider that knows I'm a trans person coming for services, and they'll still like pathologize me based on whatever they think my experience might be based on how I look. And so like over the winter I was super sick, and I actually had walking pneumonia. But when I went to the LGBT clinic that I went to be like, I'm really sick, I don't know what it is, the nurse who like was a trans provider was providing me services, spending like 5 minutes with me. She told me I was either HIV positive or I was pregnant. And this was based on like some information I had disclosed to her about the fact that I had at one point been engaged in sex work, that I slept with like men, with women, with trans people, and based on like that little bit of information that she had been given, like she like essentially it kind of terrorized me, because after she told me that that was what could be wrong with me, she left the office. And I proceeded to like call like at least one of my friends to be like, oh my God, this like nurse just told me I might be positive or pregnant, and now she's going to get like you know. So in that moment I was like, here I am, like I still check all these boxes. You have some idea of like maybe what I want, but then you think I either have this or I have this. And there's, you know, meanwhile I have like walking pneumonia. Like you gave me antibiotics afterwards, but you terrified me, and I like cussed out your HIV prevention person for leaving me alone in a room after telling me I could be positive. And like, you know, I had to go off and advocate for myself at a level that like I know how to do, because I like teach other people how to do that. But that's not a skill set that we all just get like in school or at work or somewhere. And so it's like you also don't know how to do that stuff and advocate for yourself. It's just like then you just further isolate yourself. And I almost didn't go back to the doctor after that, and everyone's like, no, you need health care. That should be exactly what you don't do. Like you should keep going. And I was like, you're right, I'm gonna keep going, because that's like I deserve to have that health care. But like that experience of having somebody spend 5 minutes with me and tell me these things, I'm like, she doesn't go to the doctor and have that experience. I don't think where they pathologize her at that level because I'm a trans person and a person of color. Those could be the only things that I do, or could be wrong. So
Absolutely. Wow.
yeah, it's a little snippet.
Dr. Watson, how would you respond to all the things that we've raised?
I think that it would be a resolution for me to say that community kinship life, which is Seek Your Life, because I've dealt with different agencies, kind of like CHN, I've dealt with the community, I've come from the community, you know, and one of the things when it comes to JCO and the electronic process at Bronx, Lebanon, where my offices operate from in the Bronx, I make sure that I am at the front desk if I have any new intakes coming in, and I do all the intakes process. Anything that's going into the registration and being registered, I check off all those that paperwork, and the person that's handling that, the MOS, who's handling that at the front desk, I make sure that they would know that if that is a trans masculine person, the name might not be legally changed at this moment, and insurance. But I make sure that all of the patients that's coming in, I tell them to send, if you have your name changed already, send it to your insurer. You know, I give them all the pointers that they need to do so that when they come in for their first initial appointment, they won't have to go through a lot of red tape. If they haven't done that, then I make sure that they get the letters, the intake process is first of all, then the consent form is offered to them, and make sure to see the doctor. But at the front desk with the charts, now they're moving from the paper into electronic, but at the same time on the charts, the paper chart, I have like, if they have a legalized name, I have their legal name, and their preferred name, so that the triage nurse would never go out and call them their name. And then when they're being triaged or having a conversation, I do all the intake process. So when I'm at the clinic, I oversee all of that process so that they won't have to run into any kind of issue. And reason for, I have trained, I continue every quarter to train all the medical staff at Bronx, Lebanon. And yes, I do agree with what you said, is that in med school, there's nothing taught about transgender issues or anything of that nature. So what we do when the attendees and the college medical students come out, we have a grand round and we train those individuals around transgender sensitivities and what is happening. Apart from that, we train the janitor and the security guard about those issues too, that if they see something that's not normal to your eyes, you got to be sensitive. So we've been successful so far, and now I oversee 2 clinics instead of 1. So basically, that's for me, that's how resulted into a positive. And I can say, okay, well, let me snatch all the transgender individuals in New York City and come to my clinic, because I might get overwhelmed because I've done hundreds and hundreds of them. And I've always implemented that at CH, and I'm always the person, like, they actually call me the transgender police, because I'm always at the desk. Any new person coming, I'm always like breathing down the neck, and I go hard to make sure that transgender individuals are not discriminated if I can be there. And if I hear about it, I make sure that it's not happening at all. So when it comes to the medical records and stuff like that, at Bronx Lebanon Community Healthcare Network, that Community Healthcare Network, oh my goodness, I love them so much. Trying to get out my head. Community Kinship Life, what we do is make sure that we have quality, intimate services provided instead of quantity, so we deal with quality.
There's so much more I want to explore here, particularly along the questions of kind of like Sasha been talking about the racial microaggressions that are also encoded within these kind of transgender microaggressions, and how community kinship is also trying to not only fill in the gap or like bridge that gap, but also kind of helping, being a contributor to like leading the larger medical care industry to move towards being more trans-sensitive, which these days this discourse is actually now out there and it's being talked about, and we have some wonderful examples. But I think community kinship is definitely a leader for like trying to create those dialogues and to create new methods of dealing and avoiding these kind of microaggressions here. That being said, going to switch gears nonetheless a little bit, and I still want to keep the question of like the racial health disparities in mind, but I want to talk about the use of the application of mental health care as incorporated within a larger ecosystem of clinical care. So care that is purely about the body, but how do we also incorporate sensitivity to the experience, the mental experience, the emotional experience of that person walking into your clinic? And before I throw this question out to the panel, I also want to make sure we're thinking about the experience of being diagnosed as a person who is HIV positive, and how that, because regardless of what structural problems create an overrepresentation of HIV within trans community or trans community of color, that is a reality that healthcare providers have to deal with. The experience both as a provider and as a patient or as a friend of someone who might, or an advocate for someone who might experience having that diagnosis made. So how do we incorporate appropriate mental health care within general services, and how do we also think about the mental health care needs of people who are undergoing diagnosis? So I will throw that very complex puzzle of a question first to Dr. Nahan to see what you think.
Sure.
Thank you.
So let me tackle the issue of mental health care among HIV positive individuals. So it's been well documented in the literature that persons who are HIV positive have significant mental health needs, even going as early as the time of diagnosis, which I think we talked about, you and I, earlier before this panel. A period of, some people call it an adjustment disorder, whatever you want to call it, a period when you are very stressed by this information and it overwhelms you. And so there are tremendous mental health needs at the beginning, at initiation of diagnosis, and they may continue down the line. Most HRSA-funded clinics, and the STAR clinic is a HRSA-funded clinic, incorporate and integrate mental health services into the HIV primary care. And so you will have an intake by a mental health professional. This person may be a licensed clinical social worker or a psychiatrist or a nurse practitioner with psychiatric experience. And they will do an intake and assess the mental health needs of the individual. And it may just be an initial intake, and they may say, this person doesn't have any further needs at this point, or they may need ongoing psychotherapy or medical support, because I don't think we should really think of mental health as just being medications. It's not just psych meds, it's also psychotherapy as a component of it. It may also be substance use treatment as well, if that's applicable in the case. So most, like I said, most HRSA Ryan White funded clinics are mandated to incorporate some kind of mental health care into HIV primary care. So I don't know if that helps answer that specific question with regard to HIV care. I also want to switch gears and just speak on and draw on my experience as a transgender primary care provider. I, as a provider, always got a lot of information from our initial screen of patients, our transgender patients when they registered for care would do an initial assessment with usually a social worker. And the reason why I like that assessment is I got a ton of information about the individual's background. It wasn't just their experience as a trans experienced person, but also history of domestic violence, history of substance use in the past, history of mental illness in the past, family history of that. And so I really liked that assessment because I found it very helpful to treat the patient in other areas of their lives as well. And so I think most programs that provide hormone therapy will incorporate some kind of mental health screen. It might be just an initial one, and then the continuation of that. There are some experts who feel that all individuals of trans experience may benefit from continued mental health support. That question, I think, really is best probably left in line with the providers and the patients to decide that issue. But I find that an initial screen is really helpful as a provider.
So it's interesting because I worked at Cal to sort of change this process that used to be when a trans patient would come in wanting to start hormones, they always went through mental health. And the piece of information that's helpful from that, we wanted to keep, but the messages that were sent that in order to start hormones, you had to be seen by a mental health provider, sent these messages to trans people that they had a mental health issue because they wanted to start hormones. So, but there's the value that you're talking about too, of being able to talk to someone about what are your expectations of hormones, what is your family support, friend support, what resources do you have, all of that is incredibly important. And so what I did was sort of change it to go through a nursing route, also because I love nurses, and because I think nurses do cover a lot of mental health issues as well. And so now when a trans patient will come in wanting to start hormones, they have a transgender counseling and education appointment, but with a nurse as opposed to mental health. But the messages are still sent that mental health is always an option, but that the same kind of conversation, because what the mental health providers were saying was, we were getting all these medical questions or nursing questions about what do hormones do, what is it going to do to my body, and they weren't necessarily equipped for that, right? So instead, being sent to a nurse makes it feel more like this is actually a medical decision to go on hormones, like you would start any medication, right? And these are the changes that are going to happen with your body, just like any medication. And you might have emotional changes, just like any other medication, right? So being able to have a conversation about what are your social supports and your needs, while also saying here are the expectations of what's going to happen with hormones, and here's a connection to a mental health provider if you would like, right? So I think there's such a long history of how trans people navigate mental health and the messages that have been sent to us as trans people about having a disorder, right? And that still exists, gender identity disorder. So that's still a message being sent to us as trans people that there's something wrong with us. So mental health is really difficult because I think it's so incredibly important to the trans community, but we've been pathologized for so long. And we also, just as my own personal experience, I've had some really great therapists and some therapists that have just wanted to ask me unrelated trans questions, like if I'm talking about, my grandfather or something, and they're like, "What was your old name?" There's not really a connection, right? So people tend to just be really curious about trans people in general. So getting the information it's really important that mental health providers, communicate that this is a trans person is a whole person, right? We're not just about our hormones or our surgery if that's what we want, or our gender. Sometimes we want to talk about what everyone else wants to talk about, like relationships and things like that. So, and speaking to HIV diagnosis, I also work with a lot of newly diagnosed HIV patients, and primarily work with a lot of specifically trans women and trans women of color come through with a newly diagnosed HIV diagnosis, and the kind of mental health needs are so important, but also being able to navigate the fact that it's navigating mental health as a trans person and specifically a lot of trans people of color that are coming in, and specifically a lot of trans women, not having the resources they need about HIV, about their HIV needs, right? And then also about trans needs, and be able to bring that together as one and not see them necessarily so separate, because it's a lot of dealing with society, dealing with gender, dealing with a diagnosis, dealing with navigating sex as a HIV positive or a trans person or both together is incredibly important. So I can clearly go on about this for a long time, so I'm just going to stop there.
All right, thank you. Sasha.
I guess just to speak to the stuff around the pathologizing, the HIV stuff, I was talking to somebody about this last night, that because of even as community, we can tell because of the way the funding streams have switched, and that HIV, MSM, these are some things that are being funded. I know of girls who have gone out there because they had barriers to get into these programs, and being positive is one of them. Well, now I'm positive, and now I can get into this program, and I can have housing, I can have these other things, and now I can live, I can actually live a life and still do this. And I think that is the scary part of feeling yay, we're getting more funding, but we're getting more funding too late for things and then it's actually making people, especially in communities of color, feel I had a friend who had recently immigrated, and she was trying to get services, and she was having a really hard time, and I don't know, after we spoke sometime later, she talked about after she was positive, she had a completely different experience, and yeah, she has to deal with that, but now she can get these other basic things she couldn't get. And so I think it's that piece is, I don't even know, in terms of how we've internalized all the stuff around us, the fact that we are doing that is really scary. And then I think, what y'all talk about around mental health stuff, and then I think about the intersection of communities of color, a lot of us will go drink or smoke or do something else because we can't access these same systems, or we'll talk to a therapist that has no idea about how racism makes us feel on top of being trans, or there actually is not competent services for us, and so we self-medicate, and that's the way we deal with our mental health issues. And I feel I know a lot of not just trans people, but LGBT people and people of color, young people, you think of marginalized communities, these people do it because they're having fun and those things, but it's a lot of us are doing it also because we're not able to receive competent services somewhere else. And then I guess the other thing that I think of with being, especially being trans people of color, is that our health and wellness, there are other systems and ways as people of color, we have gotten those tools, but the medical system is so westernized that the only way you can get mental health is to go see a therapist, when my roommate chants every morning, and that's how she grounds herself, and that's how she receives mental health. So I think it's also about having culturally competent services that actually reflect who we are, who people of color are in the world, and some of those practices that actually resonate with us, that come from us, that have either been appropriated or we have been not taught, because they actually help us take care of ourselves outside of the system that creates these things. And then I guess just to say too, I remember when I had to, functions. I remember when I had my top surgery, I had to have like a letter from a therapist saying that, yes, I have like gender identity disorder and all of these things. And when you talk about barriers, I actually went around that system and didn't maybe do it the way I was supposed to and didn't actually ever receive mental health services. And after the fact, I thought, oh, I probably should have received mental health services before I did that because it impacted me a lot after having surgery and what I thought. But it's kind of like when you said like all trans people should be receiving mental health, all people should be receiving mental health services. So it didn't matter, you know, whether I was having top surgery or whether I was trans or not. Like I have been, you know, we're dealing with trauma, we're dealing with like all the things that come up for us. Like we should all be seeking out those services. However, but it was because I was pathologized in a certain way to think, oh, just get them to say you have that thing and then you can do it. And being the person I am, I was like, I don't even have access to get somebody to say I have that thing. I have to go around that whole system and like lie that somebody even did that. That was the only way, and I was surgery when I had it. So it's like, you know, like we have continued to have to go around those systems, like for mental health services, for all sorts of things. And I don't know, I think about the rate of like suicidality in our community and stuff like that. It's like, to me, it's like because we don't have like a culturally competent service that we even, you know, have those as options.
Thank you for bringing up cultural competence. I think that's an important strain of thought that actually works very well with my next framework of my next question. But Dr. Lassie, would you like to respond?
With the mental health piece, I'm Buddhist, so I chant Nam-myoho-renge-kyo every morning and every evening, and that personally have helped me with dealing with mental health issues when they say, okay, there's a person that's medically transitioned and she needs therapy. Yes, I know I need therapy because there's a lot of stuff that I need to dump, right? And yes, my therapist, even she moved to Trinidad and Tobago like back in March. So I'm like, okay, so what do I do? Where do I go? You know, but having my Gahanza, I'm chanting Nam-myoho-renge-kyo, that have actually internalized me to say, okay, you're going to be all right. And there are things that, a technique that I use when it comes, and this is a piece from mental health, you write in a journal, and also to go back to the clients now, I run a Healing Our Women, I call it Heal Our Women, for transgender women of color. I've done this is my third cycle doing that, consulting and facilitating that group, and helping individuals deal with trauma, child sexual abuse, and intimate partner violence, right? And all the trauma that they've been going through, in which that normally in a mental health provider office, they don't talk about these kind of things. They might fill out the paper, the 50%, you know what, your diagnosis is identity disorder, but how about my life in reality? So the things that I do where my healing is concerned is to help these women understand that you can gain back your life. And yes, therapy is important, but there's a lot of other alternative ways to deal with mental health within the Constitution. And within community kinship life, when you come in to do the intake, obviously, yes, we have a structure set up that after you see me, you see the provider, you have to make a date with the therapist. So to sign up, even if it's one time, but like Dr. Hunt said, is if you feel like continuing therapy, that means that's up to you and the provider, but that is not mandated for you to do that. But as a new initial, you must see the therapist. It's mandated that you see the therapist at least once so that we can move forward with our consent form so that we do not be liable in dealing with hormone replacement therapy. We got to cover ourselves, right? And that just put every person that is transgender or a woman or man of trans experience does not need therapy. They might need therapy ongoing if they're dealing with those kind of issues. And at this time in life, I don't believe in gender identity disorder for transgender individuals because this world is full of everybody that's have gender identity disorder, right? And people say only transgender have gender identity disorder. No. That's what you do. That's stereotyping that particular target community, and I don't like that personally. Right. And I speak really against it. I highly for fact no one in community, none of my clients or members in community kinship life goes along with that. And I speak to my provider, my mental health provider for my program, and say, don't diagnose them on this because you never, there's more to what they're going through because they call me Big Mama. So, they talk to me first. So I'm like their counselor first, and they go over the mental health. But mental health is very important, but it's not a cookie cutter. It's not for everyone in life.
And one thing that you raised that I'm glad that you did was this idea that gender identity disorder kind of being defined in a very cis-centric medical profession. We've never, people of trans experience have never had the opportunity to get their voices in and say, like, let's define this for ourselves. So thank you for bringing that up. I'm going to move on very quickly to the last question before we take some questions from the audience here. And if, I hate to tell everyone to kind of like keep it, because there's so much within this question, but we do want to get some questions in at the end. So very quickly, this question I had a little trouble in the phrasing because I originally started discussing, I wanted to discuss the MSM community in particular, and oftentimes, professionals like to discuss the MSM community or men who have sex with men in this binary of down low and out, and we never really, myself included, in conceiving this question, acknowledge this kind of range of disclosure, this range of outness. How we have a different level of disclosure with different people, or perform different versions of ourselves with different people. So that being said, anybody who's along that MSM continuum of being, whether they identify as in this sort of like straight identified world where they're still having sex with other men, or whether they're out just to certain people, what kind of is it possible for a person who is not disclosing their sexual behavior to be health literate? Is it possible for them to appropriately navigate the healthcare services that they need for their lifestyle if they're not disclosing it to their healthcare provider, or even to themselves outside the vacuum of that sexual encounter? I really, again, want to reiterate that I'm trying to stay away from making that down low out binary because it's still in my head, but I really acknowledge that there is a range, and what does it mean to be health literate and also not disclosing their sexuality? I'll start with you.
You understand?
Actually, since you wanted to check
okay,
in,
I really. This is MSM. So we talk about MSM, right? And since that this is a panel, you say particularly categorize MSM, but there's several individuals that are transmasculine that are sleeping with men, either cisgender men or other trans men, right? So my thing is that a lot of them are health literate, but you talk about down low, and they necessarily want to stay on the down low of what their sexual orientation is all about. But they make sure that they get tested, they make sure they use barriers or not use barriers, depending on what that constitute, and that could be another panel discussion, because that is huge. And I had to do, I did a transmasculine MSM survey, and got back some really great results with DOH a couple of years ago, because no one believed that, okay, a person, or wondered why, a person of transmasculine experience, why would they transition and still be sleeping with cisgender man or another trans person? And it is really a fact. Gender has nothing to do with a person's sexuality or who they're attracted to. And we know that's like a transgender 101, but we're up to transgender 20. And the survey was really great to know that these individuals have the health literacy within themselves going on. Like coming into my office and they actually confided me to talk to me and tell me about it. Yes, and I understand. Do I judge them? No, but there's some others that would not tell me on when they started coming to say, I thought you would have judged me. Okay. And they, I gotta stick with transmasculine. Transmasculine individuals, MSM, they are scared, actually not on the download per se, but they're actually scared to be judged and be put out there in the forefront and say, oh my God, why would you do this? You know, stuff like that, because they've been marginalized so much and discriminated from different communities. Because coming from butch, lesbian, aggressive, those kind of channels, and coming up to be a man and then being gay or being interacting with such sexuality, that brings another red flag saying, oh my God, I can't tell them this.
Yeah.
You know,
So many margins to kind
yeah, I can't tell them that. And you know, I have welcomed my door and I've opened my arms to say, yes, we can talk about this because that's you. No one ain't gonna judge you, you know? Anyone that judge you will be dealing with an ignorant set of information that they don't know anything about. That's just my piece of it.
Okay, well, thank you so much. I appreciate the passion. Excellent. I'm gonna actually just go to Dr. Gahan just to get your response on this.
Sure. I think that disclosure of one's sexual activity is very important in the health literacy process. I can give you examples from my own practice. A lot of MSM are surprised to find out, for example, that an anal swab for gonorrhea and chlamydia will tell them that they have an infection of that area, and they can't get that information, say, from a urine test. And so I use that opportunity to tell my patients, you really need to be open about the types of sex that you're having, the parts of your body that you're engaging in sex with, so that we can provide you the right medical tests to do that. So that's a great opportunity for a provider to educate the patient, but it also requires that the patient give up a lot of really personal information to the provider. So there has to be that openness of communication, and I see that a lot among young MSM that I've taken care of, as well as trans women as well, and trans men too, who sometimes may not tell me initially that they're having sex with other men. So that is very personal information that has to be disclosed in order to do proper medical testing. So I think to be health literate, yes, you must disclose, and also the provider needs to educate the patient with appropriate information.
So Nathan actually mentioned before that the healthcare provider has a role in nurturing the health literacy of the patients who are kind of co-signing. No, I don't want to put words in your mouth. Yeah, excellent. Sasha, I want to go to you next and really look at the role of, since you, forgive me if I'm tokenizing, but since you talked so eloquently about race, can you give me your answer to this question? Also keep it bearing in mind the aspects of race and
Yeah, I mean, I guess like the question that comes up is like, what is health literacy even for that population? And like who decides what is healthy, and then if there's not even like a lot of understanding about this community, how can we even have health literacy about a community that is so isolated if there's no conversation or information out there among that community, if those people don't even realize they're part of a community or being impacted that way. So I guess I think, and then because people are coming from such different communities, like when I have been engaged in that, I'm engaged with somebody who has had a completely different experience with health and sexuality and gender than I have. And so, and then we might not even talk about what that experience means to each other, because it might just be sex, or it might be something else, right? And so I guess it's kind of hard, because it's like, what does health literacy look like at that intersection? I don't really feel like there's been a lot, like to be able to be literate about it, you have to like have some information and some experience with it. And I think there's a lack of information or experience at that intersection outside of the conversation you said, which is either DL or out, and that there's no kind of middle ground for people around their sexuality. When you meet a lot of people who, like, they don't want to go to a pride parade or those things, but they are like open in their sexuality, but there's no information out there or anything affirming them in their experience of what they're doing, so they are quiet about it or they're DL about it, even though they actually, like, I've met tons of men, cis men, who have relationships or sexual relationships with trans men, and they don't even realize that it's something to talk about. I mean, it's in some ways, and it's sexism. It's similar to like cis men who have no idea of cis women's needs when they're sexually, involved, and it's like, in some ways, I think the difficult thing is, like, even as trans masculine people, is that, like, for example, as butchers or lesbians, we were getting a message. I got this message all growing up. You can have sex, you're never going to get anything, you aren't going to get pregnant, you're not going to get HIV because you're a lesbian, so like, just do whatever and you'll be fine, you know? And then that message, like, there's a very drastic switch in your reality as a transmasculine person when you're having sex then with men, and there are like different things to be worried about or scared about. And then I think we do definitely as, I mean, I don't necessarily think people of color internalize it anymore, but like I think that we feel like we have to maintain a certain kind of masculinity or femininity. So like, yeah, I know lots of trans women who like might have might be engaging in sex with trans men or those things, but they just don't talk about it because there's an expectation of how you're supposed to perform that identity, you know. And then I think as a person of color, on top of that, there's like the, you know, the microscope is on you. Like, you know, you really feel watched, and you really feel like people already think they already know what you're even doing, and so you have to perform that. So I guess I just I think like, what does it even mean to be health literate if you're if you don't disclose? Because I do think there could be still ways to be healthy that way. If that's what's safest for you, for whatever reason, at the time, then it's like harm reduction to me. It's like, well, then how do you understand that disclosure, or how are you safe with your disclosure? Then? Like,
and safety doesn't just mean with the body. It can
totally. It can be mental health. Definitely.
And Nathan, finally to you.
I'll do a quick summary because everyone said such great things. But I think it's really the identity versus behavior is the most important thing. And, I like to train healthcare providers to ask about what everyone was saying, which is what kind of sex you're having and what kind of body parts. Because I used to go out and get HIV tests, and people would say, "Oh, you're having sex with a man? Okay, so this is the information you need." And I was like, "Wow, you have no idea that I'm talking about a trans man and that I myself are trans man." So all that information you gave me was not helpful to my body or my partner's body, right? So it's about what kind of sex you're having with what body parts. And sometimes you don't want to disclose to your healthcare provider, usually because you don't think your healthcare provider is going to be understanding or aware. So I always talk to patients about being able to use different words to describe their body too, because especially for trans people, we might not use, like, we may not identify with vagina or penis, that just might send us right out the door. And so if you say, what's the language you use to describe your body or a partner's body, we're going to use that language in this conversation. I find that patients are just way more open to, and for me, myself, way more open to talk about sexuality. So I think that's really helpful for a healthcare provider and for a patient to feel like they can talk about their own body and their partner's bodies in a different language. So.
Thank you very much. That was perfectly articulated, perfectly concise. Thank you so much. I appreciate it. All right, so at this time, I'm just going to see if anybody here has any questions. And because we are recording and using this mic, I'm actually going to ask anyone who's asking a question to just come up and assume this position on the board.
So you could repeat the question. You could repeat the question if people don't want to.
Oh, yeah.
Okay.
People, yeah.
Or I could just repeat the question after. So, does anyone have a question that they would like to ask direct to the panelists?
How was everyone's day?
How's everyone's day?
Great.
Yeah, great now, right?
Yeah, let's break that ice. Wonderful. Still.
It was awesome.
It was awesome?
It's too warm.
That's good. Good you. That was it. Thanks.
All right, so are there no questions for the panelists?
We just covered everything.
First of all, thank you. I thought this was really interesting and helpful. I manage a health literacy program at Community Healthcare Network, and we have obviously people here from our transgender or infectious disease programs, and so there's a lot of mesh. But I guess at the beginning when you were talking about preferred gender pronoun, is that something that, and I don't know whoever wants to jump in on this, is that something that you would recommend doing with every patient? Because I know, from doing different trainings, like people have mixed feelings on, let's do this every single time, let's do this sometimes, so I'm just interested in hearing your thoughts on that.
I was gonna say real quick, I say ask everyone, because if you don't, people are gonna feel like you're just signaling out people that look different or don't look like their certain pronoun. So we always say, a lot of times staff will say, well, what if someone's offended by me asking that question? And you just say, it's our policy to ask everyone. Then you actually have to ask everyone. You can't just ask people that like look like they might be trans. Otherwise, trans people might say, why are you just asking me? And then you can say the same thing. We ask every patient or every client what their preferred gender pronoun is to make everyone feel comfortable. And then you're actually just being honest that you asked everyone. That's my opinion.
I was going to say I agree, because I think it's about like a cultural shift where you shouldn't just have to ask folks because they're at trans healthcare. Like, you might not know that about anybody in their gender identity. And a lot of trans people are stealth in the services they receive. So you wouldn't even know, even as a medical provider, that they were trans at that level. So I think it's important, because that sends a message to me, whether I have a trans kid or a trans partner or I'm trans myself, that you are affirming of my trans experience in the world. You know?
We have one more question.
Yeah, I have a question. Like, if you're stealth and you don't identify as trans, like, how do you deal with your patients? If they're like, they want the services, but they're not sitting there saying, "Look, I'm trans." They're not trying to wave the flag.
I think you, from my experiences with clients, I think that, however, I have to meet that client where they're at. And if that person chooses to be self or non-disclosure, I can't go against that. I have to go along with how they identify and deal with their self, and how my services is, how can I help you? You did not walk in to help me, but how can I help you? And if these are things, information that you're giving me, that you're stealth or you're non-disclosure, I have to respect that 100% and meet you where you're at and deal with that. There's nothing else that I can do but to meet you where you're at. That's just like if you come in and say, okay, I identify as male, I don't want to be announced underneath no trans, nothing, I'm just here for the services. That's adequate. Yeah, there are a lot of transgender programs or transgender medical facilities that have a lot of people that stealth. But the lingo might show the medical, this is a catch too, it might show another medical provider that has no intentionally knowing what stealth means or what non-disclosure means, so that you would have to explain to them, so that you could gain that respect and keep your foot down. Yeah.
I would also say, like, as a trans person, I also navigate when I come out about things, because if I'm going in for a cough, do I need to tell them that I'm trans? No. Or, do I need to say, I also know enough about my own health, which is another thing. Like, I may know what questions I can answer and what questions I can't. If I'm going in for a GYN issue, I need to say that I'm trans. They're going to already wonder why I'm in the waiting room, so I kind of have to talk about it. But when I'm navigating other things that are unrelated to body parts that would sort of out me as trans, I don't always say it. So I think people pick and choose also when they feel like they need to say it. But I think the problem with that sometimes is you may not know that there could be a health issue related to that you might want to talk about, right? Like hormones or surgery. Yeah. So it does become tricky in that way, but it's about feeling safe. And however you feel safe is with your healthcare provider.
Right. I would just add, it also depends on the services that you're seeking. So if you're seeking hormones, I would just make it clear to the provider exactly what you're looking for in the gender that you identify with, if you do identify with a gender, and kind of have a dialogue about why you want hormones and the reasons behind that, so that there's an appropriate use of hormones in that case. So I think it's about giving the information the provider needs and not necessarily picking the term that gets you the service, so to speak. I just think you need to kind of communicate your needs.
I have a question. Hi, everyone. First off, thank you to everyone for coming. And my question is, based on the topics I heard so far, there's a lot of talk about trans healthcare as well as transgender healthcare. And my question is, how do people who are civil allies help characterize trans people as well as HIV positive people? And how do we, people who may not identify as trans or HIV positive, advocate those who are?
I'm just going to repeat that real quickly for the mic here. So again, the question is, you know, how do people who are HIV negative and advocating for issues around medical care, issues about HIV and AIDS, and people who are cisgendered and allies of the gender non-conforming transgender communities help advocate? Is that correct? Is that good?
I think that's a great question. I just smile whenever I get that question because I love that people want to learn about happy allies. And I would just say a quick thing, and people may have more things to add, was sometimes just bringing it up. Like, I feel like when it's for me, it's like taking a weight off of my shoulders when someone that's not going through, and I'll just talk about being trans, when someone who's not trans brings up trans healthcare issues, right? So it's not always me having to educate someone. So doing that, and same for HIV, like bringing up what are the issues that HIV positive people face and transgender people face, and bringing that up to your healthcare providers, to your community, all the time, it also sends the message that you don't have to be trans and HIV positive to care about trans people and HIV positive people, right? So constantly talking about it and bringing and educating yourself about it, I think is a great way to be allies.
Also maybe helping, you know, your friends, people who may need services, knowing what services are available. We've mentioned a lot of places here that have services, helping connect and build bridges to places that provide services for LGBT identified individuals, I think is a great way to help as well. In addition to being a voice in the community, and also to our policymakers who ultimately decide where a lot of money goes, and you know, insurance companies, managed care, etc. All the problems that we brought up on this panel.
Can I say one thing to that? I'm sorry, I'm not even on the panel, but I have something to say. I think one of the most important things that allies can do for their friends and their loved one is to actually go with them to a medical appointment, because I think for trans people, not that I'm speaking for every trans person, but they are, and as what people have talked about, they're frightening experiences, and they can be. And I think there are moments too when you shut off when you're hearing a lot of information too, and if there is someone there with you that's personally attached to you but not personally attached to that experience that you're having, I think that is one of the most amazing things. You know, even as simple as things that I know that friends of mine do is their partner or friend will bring will use their phone and actually audio record the interaction so they can go back and hear what actually happened. So I think that there are a million things that allies can do, and I think it's great. I will stop talking now. Sorry.
All right, are there any other questions? All right, first and foremost, I just want to thank our panelists one more time. We can just give them a round of applause. I answered all my questions so articulately, despite the challenges. Once again, I'm going to have everyone who came in a little bit later, just if you can give an outro of yourself. It's not really an introduction, but and where they can follow you or find you or seek your services. Starting with you, Dr. Watson.
Well, I'm here. Just letting you know, I'm one of the founders of Community Kinship Life, and a couple of things that we do through advocacy and support groups and access to healthcare and transit-centric programs. So CK Life works to create happy and whole individuals. And when I say whole individuals, we deal with individuals that live authentically as themselves, as male or female. And if they're living in between, you know, we can deal with that. But we like to support individuals that are very sure about what their life is all about. And I have sat on the PPG. I used to be the transgender chairperson for New York City and state. And I just want to say that to create a 501c3, I'm 501c3 federally known, and coming from the background of Community Healthcare Network, I was able to resign and say, okay, let me formulate my own foundation because I needed to advocate more for individuals like myself as a woman of trans experience. I'm doing this personally out of my pockets. I've never had a grant. I've never had a government grant. I don't get donations or such. I do everything out of my pockets. So when you hear that I give away $51,000 in surgeries that came from my personal pockets. And that's why sometimes, like, if somebody asks me to do something, I'll be like, oh no, I'm not doing it. I'm pulling from my pockets while you are getting government grants, you getting private grants, you getting federal grant. What I got rent to pay for, I got all that to pay for. The CK Life is actually from Kim Watson pockets, and this is what she's doing. And actually, I like to brag about the services I do and the many people that I've helped throughout the states. And we see individuals from Jersey, Pennsylvania, Connecticut, Baltimore, Atlanta, and Boston, and Staten Island, throughout the whole states. We see a lot of patients, and a lot of members are part of our community, and we have an online group also going on. So that's CK Life in a nutshell.
And what website can they find?
You can find me at www.cklife.org, or you can Twitter me at onlyonecklife.org, or you can Twitter me at idefileme 2014. Yeah, you can find me. I'm very social media, like, just find me. And if you really want to get to Kim Watson, my number is 347-9002. Come on now. Yes. And it's okay. I need donations. $5, $20. Come on. I can't get a grant. Help.
Thank you so much. Thank you. We really appreciate you being on this panel. Sasha, what about you?
Yeah, I'm Sasha Alexander, again, the founder of Black Trans Media. Recently started a community-based group of folks who are really committed to shifting and reframing the way Black trans folks are seen through the media. And we do that by creating our own media, by sharing the work of artists and media makers who are Black trans people. And some of the things we're going to be at, in case you want to catch us, is we're going to be at Brooklyn Pride, which is happening in a couple weeks. We're going to be at Philly Trans Health Conference, which is an awesome place and space to connect around all sorts of trans health resources. We're going to be in Boston in August at this event for Body Image for Justice, which is organized by these Black trans guys working around health and wellness. And there's also a whole other host of like media-based projects, Project I Am Enough, other projects that we support that are around the health and wellness of trans folks, but specifically Black trans folks.
And where can people find you?
And people can find us on Twitter at Black Trans Media, on Facebook. Our website is launching really, really, really soon. Any social media place. Black Trans Media Gmail if you want to contact us for more.
I'm Nathan Levitt. I'm not on Twitter, and I should be apparently. I'm a registered nurse. I work at Callan Lord Community Health Center, which is the LGBT health center in Chelsea. It's callan-lord.org. So I work as a nurse there, and I also work as a nurse at Maimonides Medical Center on the cancer floor. And I also do trainings for healthcare providers and training, any kind of training. Medical students, nursing students, healthcare centers. You can contact me through Callan Lord or nathan.levitt@gmail.com. And apparently I need to get a Twitter. That's all I got.
Hi, I'm Elliot Dahan. I'm an infectious disease physician at SUNY Downstate Medical Center at our STAR program. You can access our website at www.downstate.edu under the STAR program. I personally can be reached at Elliot, ELLIOT.Dahan, DEHAAN, at downstate.edu. At the STAR Center, we provide services for HIV-positive individuals. We also provide recently PrEP services, that's pre-exposure prophylaxis, that's giving the medication Truvada to HIV-negative individuals to prevent HIV infections. If you have questions about that, you can contact me and I can give you more information about that. And we will also be providing post-exposure prophylaxis as well, which is giving medications to prevent an HIV infection after a high-risk exposure, including sexual exposures. Yes, I can also be reached at 718-270-2471. That's my direct line at Downstate.
All right, and I'm Darren J. Glenn. I am a literacy advocate. That's traditional literacy, health literacy, media literacy, all kinds of literacy. And I am a community outreach consultant working for Brooklyn Bridge. And you can find more information about me and Brooklyn Bridge Project at www.brooklynbridge.org. brooklynbridge.net, or Twitter @brooklynbridge, or our Gmail, brooklynbridge@gmail.com. You're not getting my personal email. All right, thank you all very much for coming. It was a pleasure having you guys here, and I'm glad to see the interest in health literacy, and we'll continue these discussions. Thank you very much.